I will be presenting today acute kidney injury with the common etiology. So acute injury, we have in the last session we have seen like how kidney injury is common nowadays, more common in critically ill patients, and the how it is important and how the risk factors and the mortality is associated with the kidney injury. In this session, we are dealing with the common etiology of the acute kidney injury. So uh, acute kidney injury is divided into pre-renal, intrinsic renal, and post-renal acute kidney injury. So pre-renal azotemia, which contributes almost 30 to 60%. Intrinsic renal acute kidney injury contributes to 20 to 40% of the total acute kidney injury patients, and post-renal acute kidney injury contributes to 1 to 10%. This So we'll be seeing it one by one. So first we will be seeing with the pre-renal azotemia. So pre-renal azotemia, it's again the causes of pre-renal azotemia are divided into two categories. Likewise, decreased extracellular fluid volume and increased extracellular fluid volume with arterial underfilling. So decreased ECF volume can be due to renal losses, third space losses, and gastrointestinal losses. So we'll be seeing it one by one. So total intravascular volume depletion is maybe due to hemorrhage, maybe due to renal fluid loss, use of excessive diuresis, osmotic diuresis, or primary adrenal insufficiency, and salt wasting nephritis, and diabetes insipidus. There may be GI fluid loss causing the total intravascular volume depletion, like vomiting, diarrhea, or nasogastric tube drainage. Like skin fluid loss involves burns, excessive sweating, or hyperthermia. There may be third space fluid loss causing the total intravascular volume depletion, like in the cases of peritonitis, pancreatitis, systemic inflammatory response syndrome, profound hypoalbuminemia. Then effective volume depletion from arterial underfilling. Arterial underfilling may be because of the reduced cardiac output and or peripheral vasodilatation. In this case, there may be intravascular volume may be the normal, but the arterial underfilling will be there. So this causes for the acute kidney injury may be because of acute decompensated heart failure, previously called as heart failure, cardiogenic shock, pericardial effusion with tamponade, massive pulmonary embolism. Or there may be peripheral vasodilation as seen in sepsis, use of antihypertensive medications in anaphylaxis due to anesthesia, or in cirrhosis or other liver diseases. This prerenal azotemia may be because of intrarenal hemodynamic changes. Likewise, in glomerular afferent arterial vasoconstriction, that is also called as preglomerular effect, which is generally caused by NSAIDs, cyclooxygenase 2 inhibitors, cyclosporins, tacrolimus, radiocontrast dyes, or hypercalcemia. There may be glomerular efferent arterial vasodilatation, that is post-glomerular effect, which is caused by angiotensin converting enzyme inhibitors or ARBs. Then intrarenal or intrinsic AKI. This is again divided into vascular, glomerular, tubular, and interstitial. So vascular causes for the acute kidney injury in intrinsic renal kidney injury is large or medium-sized vessel diseases like renal artery thrombosis or embolism. Operative arterial cross-clamping, like in transplant patients, bilateral renal vein thrombosis, or polyarteritis nodosa. Or in the small vessel diseases like atherosclerotic diseases, thrombocytopenic purpura, scleroderma renal crisis, malignant hypertension, like HELP syndrome or postpartum AKI. The glomerular diseases causing the intrinsic renal failure, maybe nephrotic diseases and nephritic diseases. Nephrotic diseases are uncommon cause of AKI, but minimal change disease or collapsing focal segmental glomerulosclerosis may cause intrinsic AKI. Nephrotic syndrome are more of proteinuria and less of hematuria. Nephritic syndromes or maybe nephritic syndrome caused by proteinuria, hematuria, and increase in creatinine. In this rapidly progressive glomerulonephritis, also called as crescentic nephritis, or other diseases which are anti-glomerular basement membrane immune complex deposition diseases like Goodpasture syndrome or lupus nephritis, acute post-infectious glomerulonephritis, lupus nephritis, Lennox-Gastaut purpura, and membranoproliferative glomerulonephritis, or vaginal granulomatosis. There are some interstitium diseases which cause intrinsic acute kidney injury, like due to drug-induced or infection-associated acute kidney interstitial nephritis. So, a drug-induced acute kidney injury is maybe caused by various antibiotics, diuretics, NSAIDs, anticonvulsant drugs, or allopurinol. Infection may also lead to acute ischemic nephritis, like bacterial infection, viral infections, or tuberculosis infections. In tubular damage, which causes acute kidney injury, intrinsic acute kidney injury, maybe due to renal ischemia, nephrotoxic drugs, or endogenous toxins. In renal ischemia, may be caused by shock, hypovolemic shock, hemorrhage, trauma, gram-negative sepsis, pancreatitis, or hypotension from any cause. Then nephrotoxic drugs causing tubular damage involves aminoglycosides, amphotericin B, antineoplastic drugs, acyclovir, indinavir, then anesthetics, radiocontrast dyes, or oral sodium phosphosoda, which is being used for bowel preparation in colonoscopies or other scopies. This endogenous toxins like myoglobin, hemoglobin, or uric acid may cause tubular damage leading to acute kidney injury. Then other most common cause of AKI in the ICU is sepsis. So 1 in 3 patients with the sepsis are at risk for the acute kidney injury. With 19% of the patients with the sepsis, 23% patients with the severe sepsis, and 51% patients with septic shock are at risk of acute kidney injury. Acute kidney injury due to sepsis is many times it is multifactorial, and it is separate entity from ischemic acute kidney injury. It may lead to ischemia after the sepsis has been developed, but it is totally different regarding the pathophysiology of the sepsis. This acute kidney injury due to sepsis is a combination of vascular factors affecting autoregulation, intrinsic tubular damage, inflammation, microcirculation dysfunction, and metabolic reprogramming. There are some studies which have shown the patients with sepsis which are associated with acute kidney injury has almost 70% mortality in comparison with only the patients with AKI have 45% mortality. Then post-renal causes of the acute kidney injury, they are divided into upper urinary tract obstruction and lower urinary tract obstruction. The upper urinary tract obstruction again can be divided into intraureteral and extraureteral. Intraureteral may be because of the stones, blood clots, pyogenic debris, or sloughed papillae, edema following retrograde pyelography, or transitional cell carcinoma. Extraureteral causes leading to urinary upper urinary tract obstructions may be pelvic or abdominal malignancy, retroperitoneal fibrosis, or accidental ureteral ligation or trauma during pelvic surgery. Lower urinary tract obstruction causing acute kidney injury may involve prostatic hypertrophy, prostatic and bladder carcinoma, autonomic neuropathy causing urinary retention, and then urethral strictures, bladder stones, blood clots, or fungal infections like fungal balls in the bladder. Then in children, the acute kidney injury, the most common cause is gastroenteritis, which leads to hypovolemia and leading to prerenal acute kidney injury. Other more important causes in the children are congenital heart diseases and acquired heart diseases leading to low cardiac output, leading to acute kidney injury. The intrinsic acute kidney injury, another most common cause in the children is acute post-streptococcal glomerulonephritis. Another uh, another entity which leads to acute kidney injury in children is HVS. Then acute kidney injury in cardiopulmonary bypass surgeries. It longer the time of cardiopulmonary bypass, longer the higher the risk of acute kidney injury. The moderate glucose control and balanced crystallite solutions can decrease the risk of acute kidney injury in cardiopulmonary bypass. And we should follow KIDGO bundle of care during the cardiopulmonary after the cardiopulmonary bypass surgeries, like discontinuation of nephrotoxic agents for 48 hours post-operatively, avoidance of hyperglycemia for 72 hours post surgery, close monitoring of urine output and serum creatinine in post-operative period, alternatives to radiocontrast agent, and functional hemodynamic monitoring, plus volume status and perfusion pressure optimization in such patients. Malignancy and acute kidney injury. So risk of acute kidney injury in a malignant patient is almost 12 to 21% during the hospitalization. Most of the common malignancies with the highest risk of AKI are hematologic, renal, hepatic, and GI malignancies. In the malignant patients, the most common etiology for the AKI is hypovolemia and acute tubular necrosis. And, other reasons for the acute kidney injury in the malignant patients is prerenal malignant pericardial effusion, cardiotoxic chemotherapy drugs, meds. The intrinsic cause of acute kidney injury in the malignant patients may be due to paraneoplastic glomerulonephritis, thrombotic microangiopathy, tumor lysis syndrome, or crystal nephropathy. In the post-renal cause of acute kidney injury in the cancer patients may be the ureteral compression by the tumor. The prognostication of this acute kidney injury is they are high risk for a high susceptible population like old age, diabetes mellitus, hypertension, chronic kidney disease, or nephrolithiasis. Plus, with such population exposed to the factors like sepsis, shock, contrast media, cardiac surgery, nephrotoxic drugs, they are more prone to acute kidney injury. If we do early diagnosis of acute kidney injury, drug adjustment, volume status management, or hemodynamic support, and avoiding nephrotoxic agents exposure, we can decrease the risk of acute kidney injury. Thank you. That's how I finish the etiology, common etiology factors for the acute kidney injury. Ma'am, I have missed some study things. Can I just say it on the I haven't made it in the PPT, but I have just read 2-3 things about the prognostication of the AKI in the ICU patients.
Okay. But I think it's a wonderful presentation, and I think questions we will discuss in the last. Now,
okay, ma'am.
Amni, are you there?
Hello. Yes, ma'am.
Yeah. So I think we can start with your topic, drug-induced kidney injury.
Yes, ma'am. Okay, my topic is drug-induced acute kidney injury. So, medications are one of the common causes of acute kidney injury, especially in the patients who are admitted to the hospital wards or even in the intensive care units. And drug-related acute kidney injury can occur through different mechanisms. Drug can cause alterations in the intraglomerular hemodynamic. There could be changes in the intraglomerular hemodynamics, inflammatory changes. All these can lead to renal injury to renal tubular cells, causing acute kidney injury, tubular interstitial disease, and even renal scarring. The most commonly affected patients are those who have volume depletions, diabetes, congestive heart failure, advanced age, or those with pre-existing kidney disease, or those who have sepsis. Well, it usually occurs with drugs like antimicrobials, chemotherapeutics, calcineurin inhibitors. Um, in order to prevent drug-induced acute kidney injury, we actually need to understand the mechanism by which it can cause the drug-induced acute kidney injury. So there are different mechanisms by which drugs can cause injury, of which we will focus three here, which include drug-induced acute tubular injury, drug-induced acute interstitial nephritis, drug-induced crystalline-related acute kidney injury. So this is a diagram how drug causes acute tubular injury. Let's take example of some common drugs here. Um, let's take example of some common drugs. As you can see in this diagram, the first here we can see the TF, that is tenofovir. The drugs like tenofovir or cidofovir, which are nucleoside analogs that has the activity against viral reverse transcriptase. They are associated with dose-dependent acute kidney injury, and it has been seen that it can lead to acute kidney injury in some 12 to 24% of the patients. So these drugs enter these drugs are transported into proximal tubules via organic anion transporter 1, more common compared to organic anion transporter 3, and in the basolateral membrane. And from there, they are secreted into the tubular lumen, which we can see on the opposite side, on the apical side, by the transporter, which is HMATE. No, sorry, MRP2, which are present on the apical membrane. So usually this is how they are excreted. But if uh, there are any structural changes or this drug's accumulation leads to mitochondrial DNA damage, can cause inhibition of DNA polymerase and leading to structural changes in mitochondria and resulting in apoptosis. There are certain drugs which can block organic anion transporter 1 and thus can reduce the cellular uptake of such drugs like probenecid. On the other hand, drugs like NSAIDs, which blocks the apical efflux of tenofovir, can lead to increase in kidney injury. So once if we find out that the patient is having kidney injury because of these drugs, early discontinuation can help us prevent the kidney injury. Other is aminoglycosides, as we can see on the apical side. Aminoglycosides like tobramycin, gentamicin, amikacin are associated with acute kidney injury in some 10 to 25% of the patients. They are largely removed by glomerular filtration, and they are endocytosed via the MC, we can see, which megalin tubulin receptors on the apical membrane. And thus it enters into the cell, the endocytosed into the cell, from where it enters into the lysosomes, and thus it causes the structural injury to the lysosome. It forms the myeloid body there. It also enters into the Golgi bodies as well as endoplasmic reticulum, causing the cellular injury. Eventually, it enters into the cytoplasm and causing mitochondrial injury and leading to cell apoptosis and necrosis. On the other hand, gentamicin also reduces the renal blood flow, and it leads to kidney parenchymal ischemia, and thus it potentiates the acute kidney injury. Next is vancomycin. The exact mechanism as to how vancomycin causes a kidney injury is not known, but its rate can be from 0% to 20% when it is administered with drugs like piperazine and tazobactam. But the theories they have proposed is it can be because of increased mitochondrial stress or reactive oxygen species that could affect the cell metabolism as well as the enzymatic activities that how vancomycin can cause uh, drug-induced acute tubular injury. Similarly, the cisplatin as well as a platinum-based agents causes injury via the same mechanism. As we can see, cisplatin enters into the cell from basolateral membrane via OCT, organic cation transporter 2, and then it is effluxed via HMIT1 transporter. So when the concentration increases, that is when it causes injury. It causes cytotoxicity. It develops because of the development of reactive oxygen species, or when there is vasoconstriction leading to ischemia, or activation of inflammatory pathways, or production of various cytokines and like TNF alpha, interferon gamma, or interleukin 6. This occurs when there are higher peak concentration of cisplatin or pre-existing kidney disease or nephrotoxins, concomitant nephrotoxin exposure. Same way, the acute tubular injury occurs via drugs like ifosfamide or its active metabolite or its metabolite chloroacetaldehyde. So these are the drugs which causes AKI via acute tubular injury. The others are antifungals like amphotericin B, antivirals like cidofovir or tenofovir, analgesics, chemotherapeutic agents like cisplatin, and radiocontrast agents, calcineurin inhibitors like cyclosporin or tacrolimus, and bisphosphonates like pamidronate or zoledronic acid. The second mechanism is acute interstitial nephritis. The acute interstitial nephritis is actually an immune-mediated form of kidney injury that is characterized by infiltration of immune cells in the tubulointerstitium. And well, this can be diagnosed via biopsy only, which as per one study, some 15% biopsied, 15% of patient with AKI, in the patients with AKI, 15% of them had acute interstitial nephritis. Overall, they have found out about 120 drugs that have been reported to cause acute interstitial nephritis. But we'll talk about some most common culprits here, which includes antibiotics like beta-lactam antibiotics, sulfur-containing drugs, rifampin or fluoroquinolones. NSAIDs can cause like around 10 to 15% cases, and PPIs. So the good thing about antibiotics is that it can also present to us with some allergic features. It is easy to diagnose clinically, and thus we can even stop the agent causing the acute kidney injury, and thus the recovery is earlier or faster. But NSAIDs does not manifest with any typical allergic manifestations all the times, and therefore it is very challenging to diagnose the patient undergoing acute interstitial nephritis due to NSAIDs. PPIs are also very common cause of acute interstitial nephritis that has been estimated to be 0.8 to 3.2 per 10,000 person years of exposure. And they are also quite overlooked drugs. Other than that, we have immune checkpoint inhibitors like cytotoxic T lymphocytes or programmed cell death protein and programmed cell death ligand protein causing acute interstitial nephritis. Now we'll see how the mechanism of action is. So as we can see in this diagram, The drugs, they acts as an antigen. It binds to tubular basement membrane, as we can see in the top of the diagram, as in hapten or prohapten. It acts by molecular mimicry. Here they present as an antigen to the antigen presenting cells, to CD4 naive T helper cells. It is brought to CD4 cells via dendritic cells as well as the tubular cells. This CD4 cells, when binds to antigens, it leads to formation of various subsets of CD4 T helper cells, leading to release of interferon gamma, IL-5, interleukin 4, interleukin 13, and interleukin 19, which in turn attracts macrophages, CD8 plus cells, CD8 T cells, eosinophils, macrophages, mast cells, and basophils into the tubular interstitium, causing interstitial nephritis. Well, the treatment with interstitial nephritis is what they have proposed as corticosteroids, but it is we don't have any standardized dosage pattern as of now, because study is still ongoing, is what I have found out, and plus there's no proper duration yet. Described like a longer duration of
Sheetal, your
corticosteroids.
slides are not moving, huh? Beta.
Even sir, is it visible now? Hello?
Yes.
Yes.
Can you make it to complete full screen?
This is full screen, ma'am.
No, this is not.
Stop the sharing and do it again. It will move.
Stop sharing. This.
Hello?
No, that's okay. You can continue if you're not able to. No issues.
Okay. So, approximately, it has been estimated that 50% of patients with acute interstitial nephritis develop CKD. And with the loss of median of 11 ml per minute per 1.73 meters square of EGFR fall from the baseline to 6 months after the biopsy. Then the third mechanism is drug in, drug-induced crystalline-related acute kidney injury. So, hello.
Yeah, you continue.
A few things regarding acute interstitial nephritis. So the diagnosis is via biopsy only, because rash, fever, or eosinophilia are rarely seen. Patient might have presence of urine eosinophils, is what they were trying to study, but again, it is not very well significant. But the novel cytokine urine biomarkers like interleukin 9 or TNF alpha may offer some non-invasive diagnostic option for acute interstitial nephritis. The biopsies contain predominantly CD4 plus and CD8 plus T lymphocytes, although macrophages and B cells can also be seen, and sometimes eosinophils as well as granuloma can be seen on biopsy. The third mechanism is drug-induced crystalline related acute kidney injury. Here, the crystalline nephropathies are characterized by histopathologic findings of intratubular crystalline deposition. Well, kidney is a route of excretion of drugs and metabolite, and because of drug supersaturation within the urine leads to accumulation of the drug crystals. And the other cause is volume depletion or dehydration. So, excessive drug dosing, urine pH affects the drug saturation. Like example, acidic pH for methotrexate methotrexate and sulfadiazine, and alkaline pH for indinavir, atazanavir, or ciprofloxacin. And presence of underlying kidney disease also can lead to crystalline nephropathies. Well, patient in crystalline nephropathies may be asymptomatic, except for increase in the serum creatinine, and this can also be diagnosed by kidney biopsy. So the mechanism is, so drug can cause crystalline related AKI via various mechanisms. For example, like as we can see in this diagram, drug crystals, they precipitate in the tubular lumen, causing the obstruction and tubular necroptosis. This is one. Second is crystal uptake into the lysosomes as well as phagolysosome can lead to release of cathepsin B leading to tubular necrosis. Cathepsin B, it degrades, we can see in this diagram again, cathepsin B degrades the negative regulator of apoptosis, which is receptor interleukin protein kinase 1, and thus which forms it leads to formation of receptor interacting protein kinase 1 mixed linked kinase domain like protein combination form, which is a necrosome complex causing cell necrosis. And another mechanism is a tubular cell necroptosis. It stimulates the damage associated molecular patterns, and thus it induces toll-like receptor dependent inflammation and the cell necrosis. We also have the dendritic cell phagocytosis. The dendritic cell which can phagocytose the crystals present in kidney interstitium, and which activates NLRP3, which is NACHT, and PYD containing proteins. It also activates the interleukin 1 beta secretion, and thus it leads to interleukin 1 receptor dependent kidney inflammation, and thus leads to injury. Drugs which commonly leads to crystalline related kidney injury includes high dose methotrexate. High dose methotrexate, the incidence of AKI because of high dose methotrexate ranges from 2% to 50%. And the methotrexate metabolites, it precipitates in the urine. We can see it in the urine sediment, which show methotrexate crystals, and forms appears as annular structures consisting of small needle-shaped crystals that stain yellow, golden, or brown on hematoxylin and eosin stain, which are strongly bifringent crystals. Another drug is sulfadiazine and sulfamethoxazole. Because of their low urine solubility of these drugs, their metabolite as well, it especially in the acidic urine, it promotes the precipitation of crystals, which can be visualized in the urine sediment as hourglass shaped prominent striations, which are described as sheaves of wheat, and these are also bifringent. The prevention and treatment of these drugs include when the AKI develops, the treatment includes stopping the culprit medication, fluids to restore euvolemia and enhance the tubular flow rates, and avoid concomitant nephrotoxin exposure. Specific therapy is modification of urine pH to enhance the solubility, and intervention to reduce the plasma urine drug concentration. For a methotrexate, we can go for urine alkalization with pH more than 7.1. Folinic acid provides a salvage metabolic therapy, and high flux hemodialysis is also proposed for AKI induced by high dose methotrexate. And for sulfadiazine or sulfamethoxazole, avoiding excessive drugs, volume depletion, and increasing urinary flow rates and alkaline pH are considered to be helpful for sulfadiazine or sulfamethoxazole induced AKI. That's it now.
Now I will request everyone if they have any questions.
Ma'am, what is the mechanism of kidney injury in tacrolimus induced nephrotoxicity? Like, and does it cause us in subtherapeutic levels?
Yeah, Avni, you want to add something, or Maybe Dr. Ushi can answer.
Sir, but it
Yeah, he is saying what is the mechanism of tacrolimus induced kidney injury.
it causes kidney injury. It causes tubular injury actually, but I'm not very sure of if we are under suboptimal doses, because in excessive doses it causes accumulation, or if there is pre-existing kidney damage, it can lead to accumulation leading to mitochondrial damage. But suboptimal, I'm not sure with healthy kidney does that affect.
Not like that. The mechanism of tacrolimus induced kidney injury is twofold. It is different for acute injury, it is different for chronic injury. Am I audible clearly, Pratima?
Yes, sir.
Okay. So in acute injury, the injury is hemodynamic in nature. It is basically related to vasoconstrictive injury. So higher levels of tacrolimus will cause direct endothelial damage, causing vasoconstriction and reducing the renal blood flow, thereby leading to a fall in GFR, manifesting as a increase in creatinine. Associated findings will be salt and water retention, hyperkalemia, hyperuricemia. So this is an acute kidney injury seen with tacrolimus, which is essentially hemodynamically mediated, secondary to endothelial injury. This is potentially reversible. If you reduce the dose of tacrolimus, then you see an improvement in this injury. The other form of injury is what is called as chronic injury, which is not necessarily reversible. It is associated with fibrosis in the intertubular interstitium. So classically, it has been described as striped fibrosis, which means that there are bands of good tissue and fibrous tissue interspersed with each other on a kidney biopsy. So that injury happens because of prolonged vascular injury leading to areas of scarring in the kidney which heal by fibrosis. So actually the injury is more at the level of the blood vessel, and the tubular is actually the manifestation rather than the pathogenesis. Okay. So when we say tubular injury because of tacrolimus, it basically refers to reduced glomerular blood flow. Now, whenever we refer to glomerular blood flow, I think we still not have discussed the anatomy of the kidney in detail. But when we discuss that, you will realize that the part of the nephron which is most susceptible to hypoperfusion injury is the vasa recta, because these are the long capillaries which are dipping down into the medulla and coming up. And this is also the area which is hemodynamically most compromised because there is no reserve there in terms of blood flow or in terms of oxygen supply. So at that area, if you have a drop in blood flow, then you will lead to a tubular injury at that level. Okay, so whenever you speak of ATN, the commonest site of injury is that part of the tubule, which is metabolically the most active. And that is the loop of Henle and the ascending loop. Okay, so that is the metabolically most active part. And also in the medulla, the oxygen, the ATP or the oxygen, the two components which are required for metabolism to be active, are both never in abundance. They are just there to meet the need. So you need a continuous blood flow and you need a continuous supply of oxygen not to get a ATN. Understand? Also remember that the blood vessels in the kidney are essentially end arteries. So there are no collaterals in the kidney. Don't forget, okay? Have you understood? Any questions on this?
Sir, is there any cutoff level where we need to be like alert?
So for blood level of tacrolimus, you measure what is called as a trough level. So you measure the level which is taken just before the dose. So trough level is quite indicative of the AUC for tacrolimus, which is the area under curve or 24 hours exposure. Now, what you need to understand is the maximum injury will happen with the peak levels, not with the trough levels. So trough levels are indicative of AUC. That toxicity actually comes from the peak levels, which we do not measure usually. That being said, trough levels are also reflective of the peak levels in most patients. So that is why we try and maintain the trough levels. So the level maintenance is different for different indications. Like for an organ transplant like the lung or the heart, we try to maintain the trough levels in the higher range, closer to 10. For organs like liver and kidney, we try to maintain them between 6 and 8. And in long-term patients, chronic patients, even levels of 5 are acceptable to me when they are on regular follow-up, as long as they are not showing any signs of dysfunction in the graft.
Sir, what is your take on adding a additive like a azole group of drugs or a dilgem to increase the level?
So
Is
these
it
are
a
our
standard of
local thing. Yeah, so these are our local, what should I say, jugaad to maintain the blood levels of tacrolimus in the higher range at a lower cost to the patient. Uh, is it recommended internationally? No, because the purists believe that the drug level fluctuations are higher when you try and push them up by using inhibitors of CYP3A4
Yes, sir.
systems like indoles or we sometimes even use diltiazem to increase the levels. That being said, in a real world scenario, we find it very practical, and particularly in patients who cannot afford, it's actually life saving. So yes, I do use in some patients to
Okay.
maintain the levels.
Oh, thank you, sir.
Sure.
Any other question?
Sir, if we find out that the patient is having a kidney injury because of certain drugs, and if required to give those drugs, then how can we proceed with such situations? Like, can we expose them to the drugs again?
So, like, I think you're referring to either antibiotics or contrast agents, because they are the only two drugs that I feel you might need to continue necessarily in a regular clinical practice, in spite of the fact that the patient is having an acute kidney injury, correct?
Yes, sir.
Yeah, so now this is a clinical decision making. So, if you are pressed to the wall, then you always say, save the life, forget the kidney. But that you should say only in the rarest of rare situations when you are really pressed to the wall. And if you don't continue the said drug, your patient is likely to die. I'll give you an example. You have a gram-negative sepsis, septic shock, MDR, responsive only to polymyxin and colistin. Now your patient has a baseline creat of say 2, 2.5, where you know that the risk of having an injury to the kidney from the drug is much higher. So in that kind of a situation, if it's an MDR and patient is in shock, yes, I would use the colistin or polymyxin. But in case it is avoidable and I have an option, I would like to avoid the nephrotoxic drug. Same applies to contrast. If you have a malignancy and you need to know the spread of the malignancy to decide whether to operate or not to operate. Suppose a patient has a creat of 2 or 2.5. Will I want to give a contrast to such a patient? No. But at the same time, if the surgeon tells me that there is a life and death difference in deciding whether it's a curative procedure or a palliative procedure, then of course it is worth it to give that to take that chance and give the patient the contrast agent. So in a nutshell, it's a clinical decision more than anything.
And sir, changing the dosage as per the clearance that we have to.
Yeah. So that is a standard practice. We must follow that. Now here the question that I would like to ask all of you, except Pritima and Ashwin, of course, is
Yes, sir.
how do you? So Pritima and Ashwin don't answer. So the question is this: how do you measure the creatinine clearance in your ICU patient? Anybody? Do you look at Cockroach Galt in the patient from yesterday's creatinine and tell me the EGFR and decide how to adjust the drug, or is there any other better way you want to use? Am I audible?
Yes,
Hello?
sir.
Okay. Now the silence is deafening, so I thought I am not audible. Anybody
Hello.
can answer. Yes, go ahead, please.
Hi, sir. I'm Akhil.
Yes, Akhil. Go ahead.
Sir, usually they say cockroach gold and this CKD EPI, they should not be used when there is rapidly changing creatinine. They should be stable. So in an ICU, when there's a evolving AKI, maybe they're not suitable.
Absolutely correct. Absolutely correct, Akhil. So the first important step when you measure all these formulas for getting the EGFR is it assumes that you have a steady state creatinine. Now creatinine, like a lot of other molecules in the body, follows zero order kinetics. So you need 5 steady levels before you use a Cockcroft ideally. So what you actually need in the ICU is a dynamic monitoring. And what is more dynamic than real time measurement? So real time. So any molecule, any substance in the body which is cleared by the kidney. If you want to measure the clearance, there's only one formula you always use. It is UV upon P, right? So U is the urinary concentration of the said solute, P is the plasma concentration of the same, and V is the volume of urine. This simple formula can give you a clearance for any molecule substrate which is excreted by the kidney. So if you have urinary creatinine, you have serum creatinine, and you have urinary volume, you can absolutely measure the amount of creatinine cleared by the urine in that unit of urine volume. And if it is a 24 hours, if it's a 1 hour collection in the ICU, you multiply it by 24, and that is your creatinine clearance at that point in time for the last hour. So that kind of a dynamic monitoring is what is more important in deciding the drug dose than an EGFR calculated by the Cockcroft in an ICU. Okay? So this would be the best clinical way, I think, of measuring the EGFR in the ICU. Has everybody understood? Not understood? Ask again. This is very important for all of you.
But something we don't really do that often.
Yeah, we don't do it often because we do it at a spinal level, because when you look at the urine of the patient and look at the rate of the change in creatinine, it's a guesstimate when I do a round to tell you what dose to use. But ideally, that is what you should do. You should collect the urine for 1 hour, measure the urine creatinine, check the plasma creatinine at the same time, multiply it by volume of urine, and get your GFR.
Okay, sir.
Sure.
Thank you, sir.
Thank you, sir.
Thank you. Anything else, Prithima? Should we sign off?
Sir, one question. Is there any role of steroid for drug-induced kidney injury?
So that's a very broad question. I think you're referring to AIN primarily. Right. So when you talk of allergic or acute interstitial nephritis, the standard of care is withdrawal of the offending agent. Most of the times that should take care of the AIN and the patient should recover. Now, which are the cases of AIN where I would consider using steroid? The commonest thing is, when the patient is getting dialysis dependence. So the severity of the injury is what really makes me wonder whether I should use steroid or should I just try and withdraw the offending agent. So in a nutshell, Pratima, first to answer your question, I'll say the severity of the disease will decide whether steroid is used or not. Now, you're going to get better whether you use steroid or you don't use steroid. But if you use steroid, will the duration of the disease be shortened? Will the recovery be faster? I don't think there's the evidence-based answer to that. Clinically, yes, we all feel it makes a difference if you can give steroid for a short course, even with drug withdrawal, to help hasten the recovery from drug-induced kidney injury.
Okay. Okay.
Any other questions or any suggestions, any other thoughts on today's discussion? I don't think I attended the whole thing because, like I said before, I was going to be out of range for 15 minutes. So any
Yes,
questions on the discussion, please go ahead, tell me. Otherwise, we'll close then
any
if everybody has understood everything.
Sheetal, Rohan, Tejas, any question? Chandrima,
So,
Kesari?
so we can
Okay.
presume that everybody has understood AKI,
Yeah.
etiologically classification, pre-renal, renal, post-renal. Renal में all the causes, vascular, glomerular, tubular, interstitial, etiological causes, infections, drugs, all other pathogenesis, primary kidney disease, secondary kidney disease that can present with acute kidney injury. And post, obviously, you're talking about all sorts of obstruction, extraluminal, luminal, and intraluminal. Correct? Sheetal, you covered all that, right?
Yes, sir. She has
Okay,
covered it.
perfect. Wonderful. So I think that etiologically everybody must have got an idea what can cause kidney dysfunction, broadly at least. And when it comes to particular case, when we discuss a few cases, everybody will get the hang of it. Sure. I think with that we can close the session then.
Okay, sir.
Thank you, everyone.